Welcome to mpnuniversity.tv Clinical Insights. This discussion is about initiating treatment to early-stage myelofibrosis diagnosed patients and is moderated by Dr. Ramon V and co-moderated by Dr. Srdan Verstovsek. Our panel discussants are Dr. Stephen O., Dr. Brady Stein, and Dr. Neil Shah.
Myelofibrosis is a common myeloproliferative neoplasm that manifests with many symptoms. And of course, the traditional way of prognosticating this patient and to try to stratify them is to use the International Prognostic Scoring System as well as DIPSS as well as DIPSS+. However, we know for a fact that these patients can present with early stage diseases or even late stage disease. And the topic for today is to try to discuss how to approach these patients who have early stage disease. So from your perspective, Dr. Shah, how many of the patients that you see are kind of at the early phase of their disease, and what's their burden of disease based on your observation?
Well, I think it's important to really think about what terms we're using to define early phase disease. I think we all agree that that high IPSS or DIPSS+ high risk and intermediate 2 risk is late stage, and I guess if we certainly would agree that low risk is early phase disease, and whether or not intermediate stage 1 is, but it's a substantial proportion of patients when diagnosed with myelofibrosis who will have probably somewhere around 20% of patients would be in what would be low risk disease, and probably another 25% in intermediate 1 risk disease.
And in your clinic, usually, how do you define these patients? Do you use the traditional prognostic scoring system, or do you base it out of the presence of symptoms?
I use the DIPSS+. I think I've been impressed by the ability to sort of prognosticate based upon but it does include constitutional symptoms, but as you know, it doesn't include other symptoms, fatigue, symptoms related to splenomegaly. So I think it's important to realize there may be low-risk patients or early phase patients, if you will, who do have symptoms, and those symptoms certainly sometimes warrant palliation.
Wonderful. How about you, Brady? What's your experience been so far?
I agree with that. I do define the early MF as the low risk by IPSS or DIPSS. And like Dr. Shah, just because these patients are low risk technically, they can absolutely suffer a symptom burden, particularly symptoms from splenomegaly and fatigue. Splenomegaly is not prognostically adverse, but it's quite relevant to the patient's course. So we've seen a number of patients who are technically low risk who may lack any of the 8 adverse indicators on DIPS+, but they could have marked splenomegaly and marked fatigue and marked pruritus. So a considerable burden despite having a prognosis dictated by longevity.
So it's quite clear based on so far this discussion that even if you have low risk or intermediate 1 risk disease by our traditional prognostic scoring system, these people can certainly have burden of disease based on constitutional symptoms and enlargement of the spleen. In your experience, Dr. Verstovsek, for these patients, what's your traditional approach? How would you approach these early stage patients who are symptomatic?
So the situation is very interesting here. We assess the risk of dying here and not really accounting for what happens with the patients. Like we just said, not everybody is the same. And we don't usually judge our approach to a patient just based on the risk of dying, right? It's about controlling the symptoms, the big spleen, the anemia, 3 major problems. So if the patient might have a low-risk disease but has a symptomatic splenomegaly, there might be a reason to treat that patient. If the patient has advanced fibrosis but has a low risk otherwise of dying, maybe somebody, even me or our colleagues in New York, Dr. Richard Sibler, would suggest interferon to try to decrease fibrosis, to try to prevent progression of the disease. So I think it became too simplistic, just assessing patients for survival and saying, oh, you are fine. Watch and wait that is traditionally assigned to low-risk patients, I don't think it's acceptable when we have therapies that can help with the spleen, perhaps with fibrosis, preventing progression. It has to be individualized, and we need to use our medical judgment in case-by-case basis, not just based on are you going to live this year or that year.
So this brings a very important point because, as you said, the degree of fibrosis also seems to correlate with ultimate outcomes for these patients. So does that bring us to the point, in order for you to make that diagnosis of myelofibrosis, kind of see this morphologic changes from the beginning? Therefore, should every single patient then with myelofibrosis be treated, whether in the context of a clinical trial or in a standard therapy that we think can potentially change the natural history early on?
This is difficult to answer, but I think there are two questions here that are next to each other. One is the issue of fibrosis itself. It is not that easy actually to obtain the sample, like we know, and it's not easy to have pathologists agree on a degree of fibrosis.
Yes.
We know that it's been published many times, and that's why that's one of the reasons why fibrosis grading is not in the prognostic scoring systems. But we do acknowledge, we already mentioned that if you do have a high degree of fibrosis, that patient probably is not going to do as well. Now, the other issue is intervention to prevent things from developing in low-risk patients, or intervention to treat the patient for what they have, although they are low risk. So therapeutic intervention to treat the symptomatic spleen versus therapeutic intervention to prevent spleen from developing. I think these are two aspects that require a lot of thinking, and we need to design studies. Of course, patients that are suffering already, I would usually treat them, not wait for a proof that in low-risk patients with a symptomatic spleen, the therapy will help them with the spleen. I mean, it's logical.
So in your experience, Steve, for these patients that Dr. Verstovsek has been referring to, already symptomatic, constitutional symptoms, as well as enlargement of the spleen, although the spleen may not be that symptomatic yet, but primarily constitutional symptoms, what's your preferred initial approach? What's your treatment approach for these patients?
So, I just to sort of extrapolate on the discussion before, there is a little bit of a disconnect between the IPSS or the DIPSS in terms of predicting survival, and yet, other than transplantation, we don't have any treatments currently available that clearly enhance survival. So, what it boils down to is, yes, I look at the IPSS or the DIPSS, but ultimately, if I'm looking at symptom burden and treatments that can alleviate that, it's really all about that and not so much about their risk score. So if it is a patient who has symptomatic splenomegaly or significant symptoms, currently I think the best available treatments are JAK inhibitors, such as ruxolitinib, or through the context of a clinical trial, something like that.
Although, as we know for a fact that, although ruxolitinib as a therapy, it's indicated for patients with intermediate to high-risk disease. If we look closely at the COMFORT-1, COMFORT-2 studies, almost more than 90% of the cases, almost the vast majority actually have intermediate to high-risk disease. Do you think you could just easily extrapolate this data for even intermediate 1 and low-risk disease?
It's an excellent point. No, you can't just automatically extrapolate to that patient population, but I think it's pretty consistent that those patients who do have symptomatic splenomegaly or other symptoms are typically going to have improvement with ruxolitinib or another JAK inhibitor. So from that standpoint, yes, I would extrapolate, but this is clearly, these low-risk patients who have symptoms is a patient population who we don't have good data on. And so, in my opinion, it would be best if we can study that in the context of a clinical trial.
But patients bring the interferon many times on their own. You go online, you read about interferon, decreasing the fibrosis, preventing progression. Patients that are not symptomatic and have a low-risk disease, are they candidates for interferon? Are we here in need of another study? How long that study is going to last?
Well, I think this is the problem. Yes, interferon is a viable option and should be considered. Patient preference definitely goes a long way in terms of how attractive that is as an option. But studying this in a clinical trial for these lower risk patients and looking at long-term outcomes would be difficult, because these studies would need to be very long to reach an endpoint that would be meaningful.
You see, the one point that always is brought up by the patients is molecular response. Right? 20% of the patients in ET and PV area we can extrapolate this perhaps to early stage myelofibrosis, eliminate cells that have a JAK2 mutation. Now they may have other cells with other mutations, but we are so much focused on the JAK2 positive cells. And people say that is meaningful, but we don't know whether it is or it is not. Even if we consider it as such, I worry about the long-term ability to deliver interferon. If you look at the same studies in ET and PV, half of the patients are already off after 5 years. 70% after 7 years. So you can really deliver, even if the patients want it and there is compelling molecular response or possibly prevention of a progression. It's not that simple to inject yourself weekly or every other week for so many years. People get tired. Side effects come in.
Yeah, and I think interferon is also less likely to have an appreciable effect on splenomegaly. I think that was one of the original questions I think that was asked here, and but I think hydroxyurea is another option that one could also consider. I think for these low risk patients. Coming back to interferon, I mean, I think I don't know. I mean, sometimes we have these motivated younger patients, and you say, you know, if there's anybody for whom, you know, if they're willing to put up with the side effects for the potential prevention of progression, you know, you may err towards the side of agreeing with a younger patient, I think, to consider interferon. You know, I am intrigued by its ability to clear the JAK2 mutation for what that's worth, but you've raised an important point in that we don't know what that really translates to in terms of clinical benefit. But as you also alluded to, you know, in the absence of anything else that can reliably impact prognosis, I think, you know, I think if faced with a younger patient, I might consider interferon. Ruxolitinib, I'd be a little bit hesitant to use myself in an early phase patient, in part because, not that I generally like to ascribe to this school of thought, but you know, one worries that there aren't so many treatment options out there, and it does have activity. It is approved for patients in intermediate 2 and high-risk disease. I think there was an abstract at ASH maybe last year that showed even intermediate 1 risk patients can have some benefit, at least in terms of the usual parameters, although it's not approved for that. But I think, you know, I might err myself more towards saving that card to potentially play later if I need to.
Mm-hmm. Would you start somebody, Brady, like for example, if the patient does not clearly have any symptoms, again, with the perspective that maybe I'll be helping this patient, you know, from progressing down the road, would you start this patient on any form of therapy?
I think that's a really good question, and I'd like to I'll definitely answer that, but agree with you that the decision for interferon, I find the patients who do the best on it, whether it's ET, PV, or the early phase myelofibrosis patient, is the very motivated, proactive patient, the younger patient with limited other comorbidities. It's the patient who comes to us saying, I really want to be on this therapy. Those are the patients I've found have done the best with interferon. They're invested and they're willing to put up with what temporarily is going to be an adverse impact on their quality of life and on their symptom burden. It's definitely associated with side effects. And so while we can change things nicely on paper with blood counts, there's going to be a financial cost, but there's going to be a cost in the symptom burden. So interferon for the early phase myelofibrosis patient, I think it really requires a series of discussions. There's definitely very interesting signals. There's interesting literature about it, but for the early stage patient, it's ultimately unproven whether it can really delay some of the natural history. So I would be very careful with it. Of course, a case-by-case basis, considering it, but really educating the patient about not only the positives, but very clear about some of the side effects we can see with this drug.
And I think that's a great point that you made, actually. You know, if you think about it, it's not really just reserving things for the future and without having any clear, you know, expectation of what can potentially happen, but we have to come to realize there's a cost that's involved, you know, and I think this is very important. You know, do you have anything to add, Dr. Verstovsek, as far as that's concerned?
Well, I'm just thinking, what are the triggers then to treat the patients? We are talking about here potential benefits in terms of preventing progression, fibrosis, prevention of splenomegaly. We talked a little bit about patients that are low risk but have symptomatic spleen. That's not that common. When do we actually consider therapy? We don't really, again, go by IPSS if they shift from one to the other because one blast show up there, right? We just look at the symptoms, anemia, traditional way of looking. I think they are preoccupied with the risk of dying when we treat the patients here. And how big the spleen needs to become to treat, or how symptomatic they need to be for us to treat, that's, I think, coming to a medical judgment of each individual doctor. We do have patients that come forward demanding to be treated when they don't have symptoms. That's the other side of the coin, where you need to say, no, you're not, like you were discussing, too early. Wait until you really need it for the symptoms. That's the gray area that we need to probably explore it. But the other issue that I like to bring up is the now availability of this mutational screening and knowledge that we will gather, if we don't already have it, in a low-risk patients based on mutational profiling. Are these the high-risk, low-risk patients that we should be treating with interferon, JAK2 inhibitor? Because now, remember, the label of the JAK2 inhibitor ruxolitinib was even changed by FDA, that it does prolong survival, right? So there are implications of these kind of decisions on a federal level, what this means for the patients. And what about molecular profiling? Early intervention with the transplant, interferon, JAK2 inhibitor? How do we resolve that?
And this is a great point that you brought up, Dr. Verstovsek, because recently, actually, we submitted an abstract on this particular issue too. We looked specifically at cytogenetic changes and also molecular changes. We didn't have follow-up data on molecular mutations, down the road. However, it was interesting that those patients where we have serial data on metaphase cytogenetics as well as chromosomal changes by single nucleotide polymorphism array analysis. And what we found was that those patients were actually on ruxolitinib therapy. There is no subsequent acquisition of chromosomal changes. So again, bringing in mind, are we actually preventing or reducing genomic instability that can push these people into subsequent progression? But again, I think this is a question that we don't have any clear answers to right now, and would need to be done by prospective studies.
This is difficult to really say, because the risk of transformation in the prospective studies has not decreased, and there are patients that transform to acute myeloid leukemia. So, but I think these studies are being planned. I know for the fact with the JAK inhibitors in low-risk patients, and the role of mutations certainly will come to the light in everybody's clinic sooner rather than later. The data is being collected.
Yeah, in spite of what I mentioned earlier about saving your guns, as it were, I mean, I think the flip side of that argument is, and we know this for the treatment of other like proliferative neoplasms like CML, that in general, the earlier you initiate effective therapy, the more dramatic the impact is going to be. We know even for chronic phase CML, whether it's before interferon or after interferon, it makes a difference. And so one may presume that would hold true for myelofibrosis, but ideally, of course, we'd like to have clinical trials, showing us that. But it would take many years and many patients to achieve that.
Well, this has been sorry.
Well, I was just going to say that I think it's a big question, because if there really is a survival benefit with ruxolitinib, then there could be an argument made that starting treatment earlier in lower risk patients is ultimately going to be beneficial. I don't, in particular, these patients in this intermediate 1 risk group. So is early initiation of therapy actually a good thing? Treating earlier, I don't think we really know, but there's certainly an argument to be made that could be the case. And I think this is also the group in which potentially mutational profiling could add quite a bit in terms of further distinguishing those patients who actually are sort of more like a higher risk patient versus more like a lower risk patient. And there's been a flood of data coming out, I think, in the last 12 months with different mutations, such as calreticulin, ASXL1, the study from the Mayo and Italian groups identifying 4 specific genes that seem to separate patients in those lower risk groups into actually a higher risk, sort of upstage them into a higher risk group versus the lower stage group. It's still, I think very early in that we don't, though we can perhaps refine prognosis to some extent, we don't actually know what it means in terms of initiating therapy or specific types of therapies.
I think the other issue for the lower risk patient, what we're also learning with JAK inhibitors is that perhaps with a long-term exposure, you can see some changes in bone marrow histology. With long-term exposure, stabilization or improvement. And it could be a low-risk patient that has the ability to tolerate this drug for a long period of time. Going in, they may have more preserved hematopoiesis and less cytopenias to begin with. Technically, a low-risk patient is less likely to have significant anemia or thrombocytopenia. So that's also potentially an argument for earlier treatment.
That's a very good point.
So I think this has been a really interesting discussion, and again, I'd like to thank each of the participants. Certainly I think what's clear is that there are certain patients with low and intermediate 1 risk patients who have myelofibrosis who clearly have symptoms, and I think in those cases treatment with either ruxolitinib or a non-ruxolitinib based therapy is warranted. However, in terms of starting patients who don't clearly have symptoms yet, I think the verdict is still out there, and we really need additional data to follow through. Thank you.
Thank you.